Peter and I recently attended the 2019 ECCO Congress in Copenhagen. We had the pleasure of presenting a poster on monotherapy versus combination therapy usage in UC and CD, and the corresponding remission rates of these two patient segments. If you're interested in finding out more about this poster, please let us know. What we really wanted to share with you today are some of the key takeaways from the conference.
At ECCO, we learnt about some of the work that's being done to predict IBD in high-risk patients before they are diagnosed. So in the PREDICT study, there were 11 biomarkers in CD patients that were found to have elevated levels up to 5 years before they were diagnosed. However, the same was not true for UC, where there were no biomarkers identified. With further work in this area, doctors can leverage this information to diagnose the disease at the earliest stages, allowing for earlier treatment and a better disease prognosis.
There was a session on finding a cure for IBD and how at this moment in time we're not close enough to find a cure for it. Current treatment, namely biologics and biosimilars, have significantly improved patients' quality of life. However, as we all know, when these treatments are discontinued, patients' disease does progress. So there is room for improvement in this area as well. As we search for a cure for IBD, it's important to consider UC and CD separately, as these diseases manifest in different ways. But by honing in on the biology of central modules, as well as searching for environmental triggers, we'll be that much closer to finding the causation of IBD, and hopefully one day find a cure for the disease.
One of the sessions we went to covered the withdrawal strategy for treatments in UC patients who have achieved clinical remission. For 5 ASAs, it's not recommended to withdraw this treatment at any time, including in patients that have achieved clinical remission. In immunomodulators, used in monotherapy, after 4 to 5 years of clinical remission, this treatment can be withdrawn, but it's associated with an increasing risk over time of about 10% per year at risk of relapse. In combination with an anti-TNF, this can be withdrawn after 6 to 12 months of clinical remission, but only if levels of the anti-TNF are high enough in the patient's serum. It's not recommended to withdraw biologic therapy at any point during a patient's treatment, as this is associated with a 30 to 40% risk of relapse after 1 year, and this increases to over 50% after 2 years.
There was discussion about complementary and alternative medicines, or CAMs, and how IBD patients are often utilizing these. So for instance, patients might be smoking cannabis, taking extra vitamins, or doing yoga. But debate surrounds the usage of these CAMs, as there's not rigorous trials proving the efficacy of these, and there's often limited positive impact on IBD. However, additional talks about psychotherapy, acupuncture, and other mind and body interventions did point to the positive impact they have on patients' quality of life. So it's important, when thinking about an IBD patient's treatment, to consider that the patients aren't just suffering from pain from their IBD, but also that their psyche is negatively impacted by the disease as well.
There was an additional session covering travelling with IBD and how patients are limited in their ability to travel. So while most patients say that travel is important to them, over 80% feel that they have restrictions on their ability to travel as a result of their IBD. Some specific concerns were that their disease could flare up while they were abroad, they could get an infection, or there would be inadequate access to sanitation. And there is a slightly increased risk of mortality associated with IBD patients who are travelling.
On the final day of the ECCO conference, the first ever head-to-head trial results were announced. The Phase 3 varsity study showed that Entyvio was superior to Humira in achieving clinical remission at week 52 in UC patients. Additionally, Entyvio displayed higher rates of mucosal healing. Since Entyvio has historically been reserved as a later-line therapy, it'll be interesting to see how these results impact physicians' prescribing in UC and CD. With our syndicated IBD therapy monitor, we're well positioned to track this. We regularly interview 210 gastros, collecting 2,100 real-world UC and CD patient record forms. If you're interested in learning about this study or have a chat about IBD, please reach out to us.